Thank you, Mr. Chairman, and I want to thank our panelists today for sharing your thoughts on this very important subject. I wanted to ask this question. This one I think anybody can respond to, but there are stakeholders who have proposed using the electronic health record as a mechanism for measuring and reporting quality metrics, and we've got a lot of providers and a lot of hospitals across the country who are participating in the electronic healthcare record incentive program. And ideally would be it would be, I think, a way in which we might be able to get at this whole issue of measuring quality. And so I guess I'm just thinking about what the advantages and disadvantages might be of using electronic health records as a mechanism for that, and perhaps get your thoughts on that. Mark.
Just a couple of thoughts. Electronic health records do have the promise of supporting exactly the kind of quality improvements and then reporting on quality improvements that you describe. I think in practice there have been a few challenges for providers. First of all, many of the traditional electronic record systems haven't been very well designed to put together data from lots of different sources and enable you to track your particular patients in the way that you really need to in order to improve their care. And a lot of providers are doing add-ons or modifications to systems to help make that happen now. Second, from the standpoint of the meaningful use payments, so far most of those payments have been tied to whether or not basically you have electronic record systems that are capable of doing things like tracking a patient over time and maybe potentially reporting in on quality measures, but not actually doing it. And one way to better align the payments that providers are receiving and further the goals of getting better quality information out, especially around outcomes and improving quality, would be to move towards meaningful use payments and other payments that really do support doctors in using their systems to put these data together and then reporting on it from their electronic record systems. Now, there's some concerns about that may be too big of a leap, but if you don't, as I think Senator Stabenow said earlier, well, if you don't focus the payments and the goals of your financing systems and Medicare and other programs on what you really want to get, it's awfully hard to get there.
And I would say, I would agree that the promise is there. We actually, larger systems invest quite a bit of money in wresting value and information out the back end of these electronic health records. And so I think that there needs to be more work to make them readily usable. So for physicians in individual practice, I think it's a much harder climb because frankly they aren't optimized for this use right now. I think that's very possible, and I think there are ways that we can push to make that more the case, and not only possible in large systems that can make these additional investments. My center, half of my center's budget goes to making our data usable for research and for clinical decision support, and that's just not something everybody can afford to do.
Let me just, if I might, and Mr. McClellan, if you want to respond to this, or others as well, but there are also the stakeholders out there who believe that CMS has developed too many different measures in quality improvement programs. You've got things like value-based purchasing, physician quality reporting system, electronic health record we just mentioned, meaningful use program, and the list goes on and on. I'm wondering if you agree with that statement, and if so, what should or could be done to create a more strategic approach to enhance quality.
Sure, there are an awful lot of measures out there, as we've said, and as I'm sure you've heard from your constituents. And I think I'm going to maybe oversimplify things a bit, but one way of viewing what CMS is doing with all these multiple measurement systems is trying to put the same measures into each one. So in the, for example, the physician meaningful use payments, and in what the CMS is planning for the value-based modifier, you're seeing some of the same measures coming together. Unfortunately, it's a very long list of measures, and it's not really this smaller set of the very important outcome-oriented patient experience types of measures that really matter for patients. And I think with good support in terms of financing reforms, it would be easier for providers to figure out their own best ways. Dr. Lansky had said, you know, there's a lot of innovation going on in healthcare delivery, and clinicians are really interested in having more resources they can use to support better care. So if you not only tried to align the measures across these different programs, but tried to simplify them down to the measures that are really important for patients, I think it could support a lot of efforts and reduce the burden of reporting on clinicians.
Okay. Mr. Chairman, my time's expired.
Thanks, Senator.